right, welcome to the podcast. Today is episode 3 of season 2. We have an absolute legend here. It's our pleasure, our privilege to have Dr. Eric in the house. Welcome to the podcast, mate.
Thanks, man. Looking forward to it.
And how you doing? You doing good?
I'm all right. Yeah, it was a long day, but ready to rock and roll.
For those listening, it's 8 p.m. where Dr. Eric is, and it's 12 for us here in New Zealand midday. What time is it where you are, Steve? Or is it the same?
It's the same.
Because you're in Georgia, right, Eric? You're in Georgia?
I am, yeah.
And and you're in Charleston, Steve?
Yeah, in South Carolina.
South Carolina. And then
you had a little southern twang to that.
I just feel like it's a thing, it'd be rude not to. In chair 3, as I might call it, assisting today, we've got Luke Gashard. Welcome to the podcast. He was with us in season 1. I think we had you on with Bryn midway through the season and brought you on today to bounce some ideas off you. So thanks for coming, bro. Appreciate it. Hey, I got to introduce my co-host. I call him Red Mon. His name is Red Min, but you can call him the Tony Stark of chiropractic. Welcome to your own podcast, Dr. Stephen
Thank you. Thank you, Luke and Eric, for joining us.
Yes, and Stephen has his microphone. You just can't see it, but he does have it. So I just want everyone listening to know that he's very professional. So once again, thank you for joining us. Some questions here I want to get through, but really the most important question that I want to ask is how annoying was Stephen when he shadowed you as a student?
Man, that's a good one. So out of probably the 5 students that have shadowed me, you were definitely top 4 of the best.
Oh, okay.
No, Steven was actually really good.
I expect that.
It was more than once, right? I think were you with me twice?
I think I did go twice. I think so.
I think it was twice. So yeah, I got to give Steven props. Steven asked all the right questions. He paid attention. He wasn't on his phone, which I really appreciate because apparently that's a thing now.
Fair enough. Well, do you want to give us a little bit of a rundown of your education and your experience up to this point?
Yeah. So, I've been a little bit everywhere. So I grew up in North Central Pennsylvania, went to Penn State University for undergrad, where my major was kinesiology with a specialization in movement science. So it was basically bunch of anatomy, physiology, biomechanics, how you move and why you move the way that you do. From Penn State, went to University of Georgia in Athens, Georgia, got my master's in biomechanics, where I specialize in sport-related concussions. So that was my whole thesis project, and most of my research was devoted to that. And then went to Life University for chiropractic school right after that.
You were a few years above Stephen, right?
Yeah. I guess probably a year?
Yeah, year and a half, something like that.
And I obviously read you were involved in quite a bit of different research throughout your undergrad years and then even moving into your chiro years. What led you, what interests you in research? Why scratch that itch? Because so many people go through school and they just focus on their studies. So what led you to get into all those kind of that extracurricular type activity?
I don't even really know what started it. I've always just been, I would call it really nerdy, I guess. I always liked not just watching somebody do something, but knowing why they did it, how they did it. But the why was always more important. So even in high school, I was back and forth between whether I wanted to go to medical school or whether I wanted to become a PT or whatever, a PhD, that had crossed my mind. And then, I get into undergrad, and then I went to, so my first bout of research was actually at Duke University. So I went to Duke University for the summer between sophomore and junior year, and worked in there. It's called the K Lab. It's their Duke Orthopedic Research Lab, basically. And that was wow, that was really cool. And then I had to keep doing more of it. And then fortunately, when I got back to Penn State that fall, the Golf Teaching and Research Center had an open position for motion analysis student, basically to do pretty much the exact same thing I did at Duke, just for a golf swing instead of surgical outcomes.
How does that research impact your practice now? You must have a bunch of knowledge that the average chiropractor probably wouldn't have.
I have a lot of useless knowledge that really nobody needs to have. But
don't we all, though?
I would definitely say, and Steven's probably this way, it makes you more critical. If there's a new technique that comes out, I don't care what it is, whether it's adjusting based, soft tissue based, diagnosis based, whatever, you're okay, I really need to know not just how that's going to help my patients, but why, and is it worth it, and is it really going to work, and what's the research behind it? How do we know that it's not just a fad, right? Because you can sit there and adjusting in school and then be done learning forever, or you can read research and you can read books and you can go to these classes to understand why they're and where they're getting it.
And I would say tends to be something that is easily overlooked especially when you're a student and you have tests coming flying at you every week and you're seeing patients in clinic and then you feel like there's just so much stuff going on, it can be hard to keep up reading and appraising research, and even at times it can be hard to critically think, especially when it's not the easy decision to make when your peers are not, which definitely can happen in many situations. Like I've got a friend who's in osteo school and he's in that situation right now where like his peers and his tutors and his mentors, they are kind of like all preaching one thing, but he's kind of like reading research and wanting to question it. But when he questions it, he gets shut down. It's important to have this environment where your mentors or your teachers are actually wanting to bring the best out of you and wanting to talk about those kind of objective thoughts you're having about stuff. Being someone that has done the research, and you briefly talked about that before, why do you think it's so important that for clinicians, so not researchers, but clinicians, why is it so important that they know how to appraise research and can critically think?
Because you have to be able to figure out if something's legit or not. You have to be able to understand why it's going to help your patients, right? Like if a new thing comes out, like I said, you can't just be like, oh, this looks really cool, I'm going to do it and use it all the time. Well, you don't even know how it works. You don't know why it works. If I'm a patient and I go to a doctor's office, like let's just take a knee surgery, right? I'm going to get a knee replacement. If I go to my knee replacement guy, I want to know why the replacement is going to work and how it's going to work. Show me the actual replacement. Show me a model of it, why it's going to work, and how it's going to do what it's supposed to do. It's kind of the same idea with us. If a technique comes out and you're like, wow, I'm going to try that. That looks really awesome. It's on Instagram all over the place. It doesn't really matter if you can't explain it, if you don't know why it's going to do it.
And in this day and age, we are operating in an industry where things are so heavily influenced by social media. Every second clinician, it feels like, wants to get views by, cracking the hell out of some model on Instagram, which is something we talked about in the last podcast, which is interesting in itself, where that kind of part of that profession is going. I suppose it's not sexy or interesting to sit down in front of the camera and like chew everyone's ear off around your assessment protocols and the research behind what you're doing and like, your clinical reasoning. But you're going to get a bunch of likes and clicks if you're just like rotating the hell out of someone's neck and just getting a bunch of cracks. Even if you're putting those cracks in posts, like there are even some people now that I've heard of, they literally would like go in and just add the cracks in, even if they didn't get the adjustment.
You got to kind of give them credit because they're way better at that than I could ever be.
What, editing?
Yeah, putting sounds in afterwards.
Yeah, they're good at putting sounds out. They're good at editing. Gotta give them credit for that.
I don't edit anything.
Well, I hope not.
Yeah, like the few videos I have up, you can listen and the audio is playing in the background, like the music in my treatment room, because I don't edit anything. I just put words in there. I'm like, that's good. I cut it down. I'll speed it up. I'll slow it down, but that's it.
That's the proof.
In the background.
You got to hear the background noise. That's like the verification whether or not it's legitimate.
Well, that doesn't mean a whole lot. I've seen people they've had whoever's filming take a bag of chips, and as soon as they go to adjust it, they'll crinkle the bag of chips.
Oh, man. Come on.
Which is still the creativity's legit, though.
You're impressed. Yeah. Use that creativity, put it into your clinical practice. Could be great, eh?
Man, can you imagine?
So a lot of what you're saying, fantastic. I agree, especially with around the research and being able to appraise information and how that kind of steers the application of what you're doing with your patient. For someone like you, why chiropractic? Especially when it's no secret to anyone listening that there is a large percentage of the population that misunderstands chiropractic. There's a large percentage of the population that fully understands how some chiropractics can be extremely quacky, philosophical based, subluxation model based, just some of this kind of old stuff. For someone like yourself, you seem very forward thinking, very research based, very evidence informed. Why the decision to have DC at the end of your name? So
the backstory is super, super long, so I won't get into the whole backstory. I was at UGA finishing up my master's. The plan was that I was going to stay for my PhD. Had some stuff happen that wasn't going to play out. So I was kind of stuck. And I had already turned down other PhD positions and I had already turned down other stuff. The med school application cycle was already over. So I was kind of like, oh shit, I don't know what I'm going to do right now. I'm up a creek without a paddle at this point. So in high school, I played football and baseball and basketball, but football and baseball were my main ones. And I got hurt a few times and went to a chiropractor and felt really good after. Like there was one time that I should have probably missed 2 or 3 weeks of games and I was back the next Friday. So I always thought, well, oh, that was cool. And my way of learning is very hands-on, right? So that's why a lot of people go to chiropractic school is you're actually touching, and that's how you're learning is you're touching and feeling people and feeling things and moving around a little bit instead of just sitting in a classroom. So I kind of thought, man, I got to figure something out. I don't really know what I'm going to do. Fortunately, my wife's sister's husband, so brother-in-law, whatever you want to call him, he's actually a chiropractor. Different type, not real sports oriented, but he was like, hey, why don't you just go to chiropractic school? Like you'd be really good at that. So I thought about it for a while and finally just took a leap and was like, okay, I got to figure out something. Didn't want to go to physical therapy school because that just wasn't for me, standing there and kind of putting people through exercises, which is all that I had seen at the time from PTs. Like in my hometown, that's what PTs do. I know that there's a lot of really good ones and I have a ton of connections down here. And I'm sure, Steven, you have the same thing. You have a bunch of connections that are really good at they're really good PTs or they're really good whatever. The old school PTs that I had seen was just kind of, hey, you go over there and you do your exercises and you go do your exercises and I'm going to stand here and watch both of you. That wasn't for me. So I thought, all right, man, I got to do something. So I just took a leap and went.
Yeah. And why the school that you chose?
Because we already lived here.
Proximity.
My wife was born and raised just outside of Atlanta. So we were already married and it was kind of a done thing. I wasn't going to pack up and move a family to go to chiropractic school when you're already going $200,000 plus in debt. And then pack up and move a whole family away from her family and her job. And
you're saying like what you identified in the physical therapy industry is not what you wanted. Parts of obviously you're now being a chiropractor. Do you feel like you draw from parts of physical therapy? Because obviously when people hear, for people that are listening, a lot of people, they're going to associate sports chiropractor, they're going to be like, oh, like that he must do soft tissue work, he must do rehab, he must do all this stuff because he's a sports chiropractor. So like, what are your thoughts on that? What do you provide? Like, what are your services and what is your go-to? Like, what is your go-to intervention if you had one?
I mean, I provide a bunch of different stuff, right? Like obviously I look at adjusting a little bit different than a lot of people. So I look at it from more of a biomechanics standpoint. So like I take a bunch of joint angles and I want to put people through movement patterns and movement screens and overhead squats and a bunch of different stuff, right? I do a lot of soft tissue work. So I've been doing active release techniques for years. I think it's awesome. Everybody's got their own thing that they do. That's probably my main go-to is I'll do a lot of ART and then I'll follow it up with adjusting them afterwards.
Nice. And rehabilitation type stuff, movement, biomechanical interventions. What about that?
Yeah, the office that I'm in right now doesn't have a whole lot of rehab space. So I tend to get creative. Like I've got a TRX that I can hook up and throw over a door. I'll have them do a bunch of exercises either on the table or on the floor. And then, I mean, we use a website called Prehab Guys that they've got a whole exercise library that you can sit there and click and drag exercises over and email them straight to patients, and you can download the PDF into their chart and you can do everything that you need to do. They can communicate with you from it. It's pretty cool. They even have their own programs already set up, so it kind of takes a lot of the guesswork out of it. And then like I said, fortunately
that software is amazing.
Their stuff's so good.
It's so good. I love it. And it's so affordable. I think it's like $90 a year or something like that.
Yeah, it's nothing.
And I have like 3 months free, so I'm still on the free version. But yeah, it's amazing.
But then, like I said, I've got a bunch of really good PTs down here that if somebody needs more exercise stuff than what I can give them from myself or from Prehab Guys, I'll just give them the card to my PTs and say, hey, go talk with Keith or go talk with Travis or whoever, and they usually figure out the rest of it. Yeah,
so you have a pretty good network of referral, right? If you need to. Is that what you're saying?
Yeah, for sure. I try to get people that are the way I look at it is I try to get a bunch of people that I would want to go have a beer with. Like that's just kind of the way that my mindset works, because I need to be able to call you or text you or whatever. And most of the people that I refer patients to, I literally text them all the time.
And so beyond how your education shaped your practice, what led you to want to treat athletes in general?
I've always wanted to be in sports. So even if it was going to be med school, I was going to be either an orthopedic surgeon or I'm not huge on the whole blood part. So
fair enough.
Probably wasn't going to become a surgeon, but it would have been something in sports. Same thing with PT. I would have been a sports specific PT if you can do that anymore. Was an athlete forever growing up. So I started playing baseball at 4 and played until I was in my 20s, and I played football all through high school, and I've always wanted to do something in sports. And since I wasn't good enough to keep playing after high school, I said, you know what, I got to find another way to be involved in it, and this is kind of the easy way.
And your kids play sports, sounds like, as well, right? So that's cool.
Oh yeah,
You get to champion them on.
yeah. That's the fun part.
In New Zealand, it's like everyone plays rugby. Hey, Luke, it's like non-negotiable. You know, like if you're not a sporty person, doesn't matter. Strap your boots on, man. You're gonna get wasted. I loved basketball, and I loved there are other sports that I loved, but not you're playing rugby regardless. And I was a pretty good prop. But you know, it's just funny. Like everyone ends up playing. You obviously, and like you actually ended up doing quite a bit of serious stuff, eh, Luke, with rugby?
Yeah, it was. Yeah, growing up, like it's always a lunchtime thing, right? Like, you know, once the morning tea or lunchtime bell rings, you're straight off to that field. You know, playing 5-a-side, 10-a-side, whatever space you could find. Sometimes, you know, so you're setting up shoes and socks with like try lines and outlines and things.
Hard out. Bull rush,
yeah,
bro.
It was kind of just the pathway you get led through. I grew up playing some rep rugby and things. I played one season when I got to Auckland, you know, 4 years ago maybe. But from that point, it was just not worth the injury. Like it's like one rolled ankle, and even social rugby, like, you know, you're out for a while.
Yeah, I know.
I was just kind of making my way through the studies and things. It was just like you had to weigh it up long term.
What about bull rush? Eh? Is bull rush is that an international thing, or is that just a New Zealand thing?
I
don't know what you're talking about.
I think it's New Zealand. Yeah. It's one.
Okay, it's probably got another name. I'd say in America, but maybe I don't know. It's best to describe. You just run at people and just tackle the shit out of them.
Yeah, it'd be like having one guy standing in the middle, and then everyone's standing on the line, and he'll be like, right, okay, everyone wearing a hat, go, and then all the people wearing a hat have to try and run past it, and this one guy just has to like tackle whoever's coming in.
Yeah, you're just gonna waste everyone.
Yeah, eventually you get more and more tacklers, and then that last person standing, and you just get annihilated.
It's good confidence, because in a real rugby game, you can't be scared to go for someone's massive bulging quads and legs, you know, like these huge dudes, man. Sometimes like you're not, you know, these massive dudes on the field, and you're going to try to take people down. It's like you can't be afraid to get in there, throw your shoulder.
Well, I was at a Catholic school for primary and intermediate, and obviously a lot of like Polynesian, like ethnicity that end up going to those schools. And man, we used to play with them. It was terrifying. I was one of the smallest dudes on the field. They playing with
They're huge.
Yeah.
They're actually huge. And hey, interesting question for you, Dr. Eric. When I say New Zealand, what comes to mind for you? This is always interesting to hear when I ask our guests.
I don't even know. Right next to Australia, probably.
Okay, interesting. Because usually it's a pop culture thing, maybe Lord of the Rings or the All Blacks, like our rugby team. We get that a lot. But hey, next to Australia, man, hey, that works. I mean, it's like saying America's next to Canada, but it's cool, man. No, I think we probably have more beef with Australia than you guys have with Canada, to be fair.
We thank Canada for a lot of stuff.
You like them, eh?
Yeah, we like Canada.
I don't know. I don't believe you.
How do you not like Canadians? They're so nice. They apologize for everything. You can't be upset with a Canadian.
They are genuine, the nicest people.
An interesting question I wanted to ask you about is your thoughts on the word subluxation and whether you use it. If you don't use it, why don't you use it? Yeah, kind of your thoughts around that paradigm. Because I think for a lot of people that are listening, a lot of people still associate chiropractors with chiropractors that function that way. And especially in New Zealand, with a lot of people, like a lot of that style of chiropractor, adjusting is the number one thing. Soft tissue, rehab, other modalities are not used. The primary focus is to restore nerve flow, to remove subluxation. This is the type of verbiage and type of discussion that is had around chiropractic here. It'd be interesting to hear your thoughts.
So personally, I don't use the word in my practice. I don't for a few different reasons. But I don't know how it is in New Zealand, but over here, medical doctors, surgeons, like that's a legit thing. A subluxation is its own thing. It's a lower degree of a dislocation. So I don't use that unless I'm telling somebody like, hey, there's a legitimate chance that you have a sublux shoulder or whatever. And I've done that where it's like, hey, your shoulder popped out and it's not dislocated right now, but something happened. This would be the word that you would get if you went to a shoulder specialist, right?
Mm.
So I don't use it in the typical context of chiropractic. I wouldn't say that I necessarily have the animosity towards it that a lot of people tend to. And I know that that might be a hot take for some people that are going to listen to this, but I don't think that's our job either, to be honest with you. Because I get a lot of patients that come to me, and Atlanta is a hotbed for chiropractors that use subluxation. They use a subluxation model. A lot of the chiropractors went to Life, and Steven will tell you that's kind of Life's thing. I have a lot of patients that come to me and they're like, well, my other chiropractor told me that I have a subluxation. I'm like, well, they look at it differently than I do. I'm not saying it's right or it's wrong. I'm saying that this is what I think happens. And I think our job is to try and update them a little bit, right? Like, it's not just say, hey, subluxation's wrong. You don't have a bone out of place hitting the nerve, but we have our own thoughts on that. But what I try to do is say, hey, yeah, that's what they kind of think. That's the way that they operate. That's how their mind works. Mine works this way, that this joint is just restricted and we got to make it move better. Or this muscle's way too tight and the other muscle on the other side of it's inhibited. So we got to make that stuff work better. If we fix that, it might help the joint being restricted. I don't go with the whole subluxation thing, but I also don't knock it either, because I know a lot of chiropractors that make their living on that word.
Like you said, it is a hot take in a sense. It is one of those things that with I've found in the chiropractic profession, like people are usually very one-sided on that stuff, like for or against. Like it's very less common for someone to be like, oh yeah, like I do my own thing, but I'm not going to like bag on the, bag or attack on that. Like I was saying, man, some of those protocols or even some of what they do or the ideology around subluxation, like the patient outcomes can be good, like there are people that I know that function under that model that do well, but then there are also people that function under that model that I would consider unethical. For me, it's like a hard one bouncing between the two. Do you have people like walk-in patients, just do you see general population still?
Oh yeah, I see gen pop. I wouldn't say walk-in. Like, we don't get people that just walk in off the street typically.
Do you find those patients have preconceived ideas of what a chiropractor is and you need to communicate to them the differences? And if so, how much importance do you put on communication with patients?
I would say a lot of times people have a preconceived notion, whether it's because they went to a chiropractor before, or lately we've had, and Steven, you might have had this too, we've had a string of patients come that have never been adjusted before, but it's like, okay, yeah, but I've seen the videos on Instagram, or I've seen, I'm not going to talk about a specific name of a technique, but I've seen somebody wrap a towel around somebody's neck and pull really hard.
I interrupt this podcast to thank Raisies for sponsoring the Strength and Chiro podcast. Raisies is a family-owned New Zealand business that only produces high-quality, all-natural and clean products. If you're anything like me and you need a protein that tastes good, mixes well and contains no additives or nasty preservatives, this is for you. This protein is New Zealand made, ultra-filtered, gluten and GMO-free with no artificial flavors or colorings. If you are an athlete or you love to train hard, it's essential that you get an adequate amount of protein. We would like to thank Raisies once again for sponsoring the podcast. You can get 10% off at raisies.co.nz.
Please don't do that to me.
You're so nice.
I try to be, because I've had people knock the way that I do stuff, and I'm like, well, that's just ridiculous. You don't even know me.
Is Eric really nice, Steven?
He is. He's a nice guy.
Well, I mean, it's good. It's not bad.
But he's a very straightforward guy as well. No messing around.
Did you have a favorite lecturer or mentor at your college, Dr. Eric?
Oh, Dr. Marnie Capes, hands down, for sure.
Steven, do you know who that is?
Yeah. She's a little teeny tiny petite person who very not so humbly will mention that she's adjusted Shaq before.
Oh, okay.
She won't say his name. She'll say his shoe size.
How do you know it's him?
She was awesome.
Little lady. So small. She's great.
Her and Dr. Capes and then Dr. Rao, Steven, they were like...
Yeah, he's amazing.
They were phenomenal. I had one extremity class, Steven, where it was the two of them together.
Oh, you got lucky.
Oh yeah, they were the two instructors on it. Man, that class was
Yeah.
awesome.
Did you have a most interesting lecturer or mentor? Not saying worse or anything like that. I'm just saying most interesting because there's a person
Ooh.
that keeps popping up every time I ask someone from your college. They say the
So
same person.
let's reword it and say, what's the wackiest thing
Yeah, there you
you
go.
heard in chiropractic school?
Ooh, that's a good one. Um, Man, the wackiest thing, and
Or just
I'm not gonna say who said it. The wackiest thing was that somebody said that they adjusted C1 mid heart attack on a friend, and it stopped the heart attack.
Oh man, I think I've kind of heard that myself.
I'm sure somebody else has talked about that.
so you're the first person who didn't mention SOT.
Yeah, that was its own separate thing. I
Well,
heard some of the stuff that Mike said from SOT and that
yeah.
you said. I didn't hear any of that. So I don't know if I was just in a different class,
Okay,
a different
yeah.
lab, or if I just checked out that day. But
Maybe you were on a bathroom break, an unsanctioned bathroom break, because we
yeah,
know
I
we
might
all
have.
took a lot of those.
They were frequent.
When we were in the library once at NZCC, we were just like casually looking at books. We weren't even like looking for anything weird. And like the Logan Basic like coccyx adjustments, like was not like in this book, and like the diagram was so rude, and like we were just losing. It was very descriptive, and the imaging, and then they did kind of bring it up in they did bring it up in class. But I think the funniest thing that we probably heard, Luke, was when talked about
Oh, yeah, I know you were going to say that.
like his patient was having a heart attack, so he called the ambulance, but he adjusted him, and then he called the ambulance. So I thought that was a funny
Nice.
story.
At least he called the ambulance.
Yeah.
We had this one guy who works in the administration at Life, and he told us that their son went blind from an accident. And so he was in the hospital adjusting his neck every hour on the hour until
Wow.
his son's vision came back. And a really good friend of mine said he probably was just like, he said it so his dad would stop adjusting his neck. He was like, Papa, I can see again. Please stop touching my neck.
I can see. Fuck off. Oh,
There are a lot of those stories, and you have no idea if any of them are actually true or not, and you'll never know if they're true.
exactly. If someone was to ask you around starting out and doing their own clinic versus working for someone straight out of college, what would your advice or thought process be for that person? I mean, that's kind of Luke. Like Luke is literally graduating in a few months. So, but yeah, what would you say?
So, yeah, Luke, good luck. That's what I would say. If you're not good at marketing, if you're not good at communicating to patients what you do and how you do it, and I think most importantly, if you can't tell people not why you're better than everybody else, but why you are at least comparable to everybody else, don't open right away. Like I would not have been ready for that. That's just me. Communication's ever really been my strong suit. I'm very analytical. I'm very nerdy, and I can explain stuff in really complicated ways that I understand. I was not good at bringing stuff down and talking to patients the way that they deserve to be talked to. Like I couldn't bring it down to super quickly and easily explain it to somebody. Like they always tell you to have what they call like an elevator pitch, right? You have 60 seconds to tell somebody why you do what you do and how you do it. I would not have been ready for that. If you know that your clinical skills are, I mean, I wouldn't even say great. If they're decent and you can do all that stuff and you have the extra money, go ahead and open. But if you're not ready for that, find somebody that can teach you some different stuff. Like I worked at an office before my current office, and they were probably 90 to 95% soft tissue based. And for me, that was awesome because I can adjust. Like I'm not the best, but I'm pretty good at it. So I learned a lot of soft tissue stuff that I use even now. And I learned just a bunch of different sports injury type stuff, right? And now my current office, we do a lot of that stuff. It's all, not all sports, but it's mostly sports. It's mostly athletes.
What would be your main demographic regarding type of sport?
I don't really have a type of sport that I see a lot of. So like I see everybody from, I mean, weekend warrior type stuff, like CrossFit's huge in Atlanta. So I see a lot of CrossFitters. I see a bunch of powerlifters somehow. I don't really know how that started, but that's been fun. It's a whole different, I mean, it's a whole different group of people. Like y'all battle through some stuff that I don't know how you do it, but you do it.
I was having a look through your Instagram as well, and I saw like a couple of photos of different powerlifters. And who's that? Is it Jamal? Was it Jamal? The deadlift, the
Jamal,
guy.
yeah.
Yeah, he did.
Yeah.
He did that pretty beastie deadlift. It was above 500. It was sumo, but it was pretty impressive. His leverages, man, and genetics. And he's just
Yeah.
born to deadlift. It's like butter. Watching him deadlift. It's a beautiful thing.
I feel like his last pull, I want to say he got like 1030. I know he pulled 1016 for sure. And that's pounds. I'm not doing the conversion to kilos.
Yeah. It was definitely over 500, but I can't remember what it was. But regardless, that's interesting. So you kind of see a little bit of like all different types of sports people. Funny thing about CrossFit is like everyone kind of jokes like CrossFit pays your student loan because they just tend to injure themselves so much. I don't think I've ever had a friend that did CrossFit that didn't hurt himself. Actually, no, I had one friend. I've had one friend that does CrossFit that hasn't injured himself, so he's doing pretty well. Otherwise, they push it pretty hard. And they definitely get some injuries along the way. So it doesn't surprise me that you tend to see people like that.
Part of it too, like when you're doing CrossFit, you are in their world. Like if you are full on in the CrossFit, it is like it's a lot on your body, but B, you kind of just fight through everything because that's what everybody does. Everybody at your gym is fighting through somebody, and nobody says a word about it. You show up, you work out.
So true.
And you go home. Like that's kind of the CrossFit way. And I did it for a while and I loved it when I was doing it.
Yeah. It's the community.
Also, if you can afford CrossFit, you can afford to see a chiropractor. So it's easy money.
Tend to hide behind the injuries as well. Like I know, you probably heard of Tia Claire Toomey, 5-time, 7-time fittest for women on earth. She was close to pulling out of the last CrossFit Games because she had some severe lower back injury going on. And like you see everything on social media, especially with the top guns of the sport, like you just think that they're training all year round without any niggles, You constantly see them getting wins and heavy lifts and comps, but like there's so much that goes on behind the scenes too that they're probably trying to battle through as well.
They just push through stuff, man, and it's the thing. But as the classic thing with social media is what you're seeing as a highlight reel a lot of the time, and there's always exceptions. Obviously, there's certain people that are honest about their journeys, but it is hard not to get this kind of perception, especially with professional athletes, that they are always high flying, always smashing these workouts with fantastic results. And when the reality of CrossFit, when you're in the trenches doing it or treating people, they tend to pick up a hell of a lot of injuries, man. And they kind of bash themselves up pretty hard. I've done quite a bit of programming and specific strength coaching for CrossFit boxers, and I would make it my goal or my duty to try and implement some movement proficiency theory into their programming, because it was just all balls to the wall and really never really slowing down for anything, let alone technique. And you've got these people that are coming in, that kind of weekend warrior type, and they're just absolutely pushing themselves as if they were an athlete. And you're just having this, you just tend to see injury after injury after injury. And so, I remember when we were doing that, we did quite a lot of work on trying to just some fundamental movement patterns and stuff like that. And then I ended up training some of the CrossFit coaches, and a few of those CrossFit boxers here in Auckland started to implement some of those protocols. It was really cool to see. And actually the whole thing, you think you would lose, like you don't actually lose any community, and you don't actually lose any of the intensity either if you're programming in time to work on technique or technical ability or movement proficiency. It doesn't take away from that, it adds to it. And so these boxers, man, they were doing really, really good stuff. My best friend was one of the managers, so I'd come see my best friend and I would see people just going so hard, man. And it's like intensity first and everything else comes last in terms of technique or worrying about, especially when you're under load, it's just like one of those things. So
it's like Matt Fraser competed for a while with a L5 pars fracture, I think. Like, just from going balls to the wall all the time.
Yeah, they train pretty hard, don't they?
Yeah.
But the top guys are just weapons. Like, there's just no way. There's just, no disputing. Like, they're just the absolute weapons. I do find it funny though that like they crown them like what is it, like the fittest on earth. Like, I do kind of find that funny. And being a powerlifter, like I even find it funny that they call strongman like strongest. like World's Strongest Man, because like it was just so like a lot of their lifts are just so it's not really sanctioned to the level that it should be if you're going to call somebody the World's Strongest Man. Especially some of their static lifts, the protocols around their static lifts, it's just like super loosey goosey. But anyway, I don't want to get into those politics. But okay, Christian, Dr. Eric, what are your thoughts on ongoing, reoccurring wellness plans?
So I don't call them wellness plans, but I do offer them. I am a proponent of them for a few different reasons. A lot of chiropractors do it different, right? Where it's, you need to be in here once a week to get adjusted. You need to be in here once every 2 weeks to get adjusted. And it's just the way that it is. Mm. So what I do is once we get somebody fixed, right? Like, you injure yourself, we get you back, you're 100% doing what you want to do. I call them keep your body right. It's kind of what I tell patients, like, hey, depending on how active they are, what sport they're playing, or like my pro athletes is a whole different thing. They do it more just because they feel really good when we take a look at what's up. Mm. So I'll tell people, hey, we got you in a really good spot. You're good to go back to CrossFit, or you're good to go back to lifting, or doing whatever you want to do. Why don't you come back in 4 weeks, 6 weeks, 8 weeks, depending on how active they are, whatever they're playing or doing. And then we put you through some movement screens, or we, just see if there's anything that is starting to show up as a problem. Because that's part of it too. It's not just, hey, wait till you get hurt and then come back. Well, I think that's kind of a disservice too, because we can do a lot of stuff where we can, I don't want to say predict, but we can at least tell you with a high chance of probability that, hey, if I don't fix that issue that you got going on, man, you're going to be hurting.
If you can modulate someone's pain and, without the intervention of surgery or drugs, that's a great modality. That's, that's definitely something that's going to be adding to that person. And I suppose if you're a high level athlete, you're really looking for that. Some people say the 1%. I say the 0.1%. When I was pushing it to the limit as a powerlifter, I was doing everything. And after a few years, you've tried everything, man. It's like, 1% is too much. Like, you're looking for the 0.5%. You're looking for the 0.1. You're looking, and if you can go to a chiropractor and they can make you feel better so that you're moving better under load the next day or for the subsequent training sessions, there is a huge amount of benefit to that. I suppose the distinction, and like you said, you don't use the word wellness because I suppose people have a negative connotation towards that. But that is because I suppose in my mind, a wellness plan would be closer together, more of them reoccurring repetition rather than like 4 to 8 weeks or in those, or even monthly. It would be like weekly, multiple times a week to that type of point. But then even in that situation, it's also context because, like I said to you, if there's a place for it in some people, in some subsets or demographics of the population, especially with sports people, I can understand that. I suppose for me, Giles Geyer put it best when he said, if you need to take out a second mortgage on your home for your chiropractic bill, then something's wrong.
Yeah, I love that one. That was a good one.
We talked a little bit about the stuff that you provide. You obviously are certified in a few different things. In your opinion, for the chiropractor that is, like I said, similar to before, just about to graduate or is graduating at the end of this year, what other modalities what certifications are worthwhile that you know about? Like, what would your opinion be? Because people are just bombarded with certifications. People want your money. People want you to have their letters after your name. And as a chiro, it's just like, in your opinion, what's worth it? What's not? Like, do you have any thought process on that?
If you can't adjust, none of them are worth it. I mean, I'm just going to throw that out there. If you're not good with your hands and can't adjust people to begin with or manipulate, whatever you want to call it, the other stuff's not going to really make a difference. If you're good at that stuff, let's just say that's 75% of what you're going to do, right? 75% of what you're going to do every day. And Steven, you might have a different number, but it's like 75% of what you're going to do is probably adjust people. The other 25% is going to be whether it's soft tissue work or rehab, or like you should have something else. If you're just having people come in and adjust them, there's a whole lot of stuff that you could be missing. I think it completely depends on what demographic of people you want to work with, right? Like I work with a lot of athletes, high-level athletes, recreational athletes, whatever. For me, the CCSP was awesome. The Certified Chiropractic Sports Practitioner. We can't say physician in Georgia, so you have to change it. But the CCSP is great because it literally says, hey, I am a sports guy. Like, this is what I do. I study on this. I keep up with it. So if you're an athlete, you can come see me and you know that you're going to get some pretty good stuff if you go to a CCSP. For me, ART was awesome. Some people don't like it. Some people don't want to pay for it, which I get. It's very expensive. It was awesome. The way that they approach it, the way that they teach stuff, the way that they take you through it, and the way that they make you learn how to palpate stuff, like how to palpate soft tissue structures, is just phenomenal. And you will have the best grasp of anatomy from taking an ART class that you could ever get.
Wow.
But that's obviously biased because I do ART all the time. So,
I mean, Stephen, what would your thoughts be answering that same question?
Yeah, so I agree with Eric. Like, if you can adjust, especially like society, when they think of a chiropractor, they think of adjusting, even if you're not going to adjust every patient. If they don't perceive you as being competent with adjusting, them trusting you with other things, it's probably not going to go very well. So if you can't own the adjustment, you probably won't be able to sell the other things. Maybe they don't respond to the other things like you're hoping they will, and you haven't adjusted them. They're like, well, wait, they didn't adjust me. I don't feel better with the soft tissue stuff, the rehab stuff. I don't feel like I got my money's worth out of it. And they're going to be like, that's just a waste of time. Like, that person doesn't know what they're doing. So, absolutely, the adjusting, get good at that first. Make sure, if that's not already a thing, work on that. And then you got to figure out which demographic you want. Like, who do you envision working with? And then find out what they need. And then go do those things. Don't like go learn all the things and then be like, I don't know who to work with, because that's what you're going to be left with. You can be like, I don't know who to work with, because you can do all these things, but you don't know how to apply them. So when you look specifically at certain demographics, you're like, okay, these people tend to have these types of injuries, and this is how you would typically treat them. So these are the things I want to go learn. So you got to kind of make your toolbox based off of, are you going to be a carpenter? Are you going to be you're going to lay tile? Those types of things. Like, you got to know what you're going to do before you build your toolbox. And then over the time, you can start adding in new things, diversifying your demographics. But you should start somewhere, even if it's just general pop. Like, just get really good at adjusting, and just some very easy soft tissue steps can go a long way. But if you already jump in, you're like, oh yeah, I want to work with CrossFitters, then you're gonna have to get a little heavier on that soft tissue, because their muscles are shredded and dehydrated, and you're gonna kill your thumbs if you don't know what you're doing.
And
Or you
for
deal with a lot of geriatric people, you're gonna want to know some rehab really good to prevent them from falling, breaking their hips.
So here's what I would say too. You got to kind of, if you can, you got to kind of find a niche and just go all in on it. Like, let's just take the CrossFit thing. Become a CrossFit coach. You don't have to coach, but take the class so you understand what they're talking about. You understand the verbiage that they're using. You understand what they're saying when they send you somebody. Or like golf. So I just finished the TPI class and I'm TPI certified now. I did that so I can understand the golf swing, because I work with a lot of golfers now. And even though I worked in a golf lab, like the words that they used, I looked at a golf swing differently. So golf coaches use a bunch of these different phrases and terminology that I've heard before, but I'm like, I don't know what they're talking about. So now I actually get it. And I know if a coach sends me somebody and says, this is one of their swing faults, I can put them through a screen and figure out why that's a fault. And I can give them the exercises to do it. It doesn't have to be golf, but there's stuff for almost every sport. Just go all in and learn as much as you possibly can about that one thing. And then be really good at that one thing. And once you get really good at that, then it's going to branch off to other people and other sports and other demographics.
And for people that, so you both of you very strongly said, hey, first things first, if you're going to have DC after your name, if you're going to be a chiropractor, be good at adjusting, right? We can all agree on that. For those people that don't feel like they get the education that they need and they're not confident in their adjusting, what would you suggest then? Obviously, we talk a lot on this podcast about MPI, but yeah, what kind of extra type of certifications or education would you suggest for those people?
I mean, obviously MPI is awesome. I've taken some MPI classes. It's great. If you don't want to go the MPI route, find somebody that you know that is a successful chiropractor and just ask them to show you some stuff. Most of them, for the most part, they're pretty good about it. You'll get the occasional one that's like, no, I'm not teaching you anything. I'm not going to help you out. You're competition or whatever. But most of them will be like, yeah, come see this. Let me show you this cool thing. And you're like, wow, that was freaking awesome.
Yeah, MPI, absolutely. I know that's exclusive to chiropractors. I know ICE, it's something clinical excellence or something like that. It's run by some PTs. I also know that Structure and Function just released the manipulation thing, and obviously our friends over in OMT training, like go use those
Yeah, like, their
resources,
stuff's
learn
awesome.
how to work the joint through its motion, learn how to manipulate it.
Yeah, I definitely OMT. We had Giles on the last podcast, and one of the great things about them is that they are very well educated in their research. Giles and Jimmy put together, and ETL put together a really cool graph, kind of going through the possible mechanisms behind why adjustments are so successful in a clinical setting. I used a lot of their research in my first thesis, also did a similar thing looking at the possible mechanisms. Differentiation between theirs and mine is that theirs was like high grade evidence, this is what we think is happening. Mine was like, these are all the things that could be happening. So like I included like dentate ligament theory and, you know, all these different types of some of this Heidi Havoc stuff out of New Zealand with neuroplasticity. And I was just throwing a lot of stuff into my one when theirs was a lot more focused. But if you want to have a little bit of a scope around the why behind the technique, OMT are really good. And they're also a great option for those of you out that are listening that are not chiropractors, but do want to get better at adjusting, physios or osteos or whoever else are licensed to do so in different parts of the world, you know, because it changes based on country for sure. We briefly talked about before the adjustment. And I would love, like, if you're willing to, I would love to hear your thought process around what is happening, because I know you briefly mentioned like biomechanical angles and making change to restriction, but then you also said that you're really good at explaining things in detail. So I'd love to hear not your elevator 1 minute, not your elevator pitch by any means, but your thought process behind what is happening when you're adjusting and why you consider or hold it as such a great intervention. And because obviously both of you just said, hey, if you're a chiropractor, make sure you're good at it. So obviously you guys both believe in adjustments are fantastic, which I would agree with. But yeah, what's your thought process behind the mechanism?
So much science that goes into that. Like, I don't know if every chiropractic school had this, but Stephen, we literally had an entire quarter on the science of subluxation theory, whatever you want to call it. That's what the class was called. But we had an entire quarter on what happens and why adjusting helps. So what I usually tell people is, and I try to keep it pretty simple. So I'll give the simple version and then I'll give the more complicated version as quickly as I can. The simple version would be, you see how when I push on the spot, it doesn't really move that well? That's messing with a bunch of stuff and we got to make it move better. And then you make it move better and the patient gets up and walks around or they move their neck and they're like, wow, I feel so much better. The complicated version would be, you know, man, there's a really tight muscle that's pulling on a spot. Like, let's just take an SI joint because that's the easiest one to explain. You've got a really tight hamstring, or hamstring's a perfect example because hamstring will come up and form the sacrotuberous ligament, which then forms along dorsal sacral ligament and goes the whole way up into the SI joint and the lower spine, right? So I'll usually say, okay, look, your hamstring's super tight. I'm going to fix that and I'm going to fix this ligament and then I'm going to adjust it and make it move better. What that's going to do is tell your brain, hey, this joint can actually move well. Like, you don't need to be freaked out about this, brain. It's okay. This SI joint can actually move now. It just had a problem and we fixed that part. Obviously, it gets rid of pain modulation through a whole bunch of super fancy mechanisms. And if you just look at how people move, the biomechanics of adjusting is actually super straightforward. Like, you don't even have to get complicated with it. This segment doesn't move that well. We're going to make it move better. Like, that's really all the more complicated you need to understand it, at least in my opinion. I don't have a lot of people coming up to me and saying, what did you just do and why? Why did adjusting work?
So do you do any mobilization in your office?
I personally do, yes, for a bunch of different reasons. Like, sometimes people just don't want to be cracked, which is fine. I'm not all about that. If you don't want to be cracked, I'm not going to crack anything. But mobilizations are super, and I know Giles talked about it, but mobilizations are a super easy way to get some motion back into a spot. And I know he actually mentioned like mulligan technique type stuff, and he's not a big fan of it, and I get why. I'm kind of on the other side of it. If I can take a joint that's restricted and pump some fluid into it and get some movement into it so the brain says, hey, that felt really good, I can go a little bit farther. That felt great, I can go a little bit farther and a little bit farther and a little bit farther, and you keep introducing a pain-free range of motion into it, then that might be all that it takes. You don't have to manipulate everything. You just need to tell the brain, look, I know you've been locked up for a while, and I know that this feels pretty bad when it's not moving right. See how much better it feels when we make it move better.
Absolutely.
Mobilizations are awesome. They work really well. I don't think it's a replacement for adjusting or manipulation, but it depends on the person. It depends on what you're doing, what joint it is, what body part it is.
We have a research article coming out that pretty much puts it like side by side. It's hard to find many differences on a physiological level, because you could say, well, the cavitation, but then the classic ideology around cavitation is, well, you don't need a cavitation for it to be an adjustment. So I suppose it would be like, it comes down to the verbiage, it's like an adjustment versus spinal manipulation versus a cavitation, a synovial cavitation, spinal manipulation versus, a thrust HVLA versus an LVLA. It just turns into a bunch of how you say things. End result is the patient. And I think that's what everyone agrees on. It is refreshing to hear certain chiropractors, and yourself and even Stephen, both say, hey, yeah, we use mobilizations. It's great. Because sometimes when I talk to chiropractors, I feel like that's a swear word. I can't say the M word. Like low velocity, amplitude thrusts or mobilizations are almost the devil. When we were in our technique classes, me and Luke were told by our mentor, if you joint play something too long, you're going to mobilize it and it's going to change for a few minutes and then it's going to go right back to being out of place again. And you have to adjust it. You have to have a cavitation, or you have to put the bone back into place. And so a lot of chiropractors, that's the education they get, especially in New Zealand. I tend to like to challenge that. I'm not trying to attack the profession, but I like to investigate. I love to be like, okay, what are some of the mechanisms behind this? Why is mobilization and low velocity amplitude thrust, or rhythmic movements, why are they so taboo in student circles? Or why do people think that they're not as important or not as effective as intervention, especially when you look at the research and it says one thing? So I find that real interesting. Just to plug my own study, me and Luke have a comprehensive x-ray review coming out on using x-rays for postural reasons. That's going to definitely be an interesting one as well. So while we're on it, do you have an x-ray machine in your office? Do you take x-rays? No. Do you use x-rays? No, not a...
use them, sure. Like, I don't use them for the type of stuff that most chiropractors do.
Oh, not postural, but like if you had an athlete or a client come to you and obviously they have a serious issue and they have the appropriate accompanying imaging, of course you're going to look at it. I understand, but
right.
Traditionally speaking, obviously, you're not sitting there with your Gonstead line drawing up postural.
I do not do that, and I will say, but I've given this advice to a lot of chiropractors over the last few years. If somebody says, "Hey, I have an X-ray. Do you want to see it?" Just ask for the report. If you don't feel like, not that I don't feel comfortable reading it, but if let's just say somebody brings me a disc and I pull it up and on this x-ray, there's one little tiny thing that the radiologist also missed, but I missed it too. I'm held to the same standard as the radiologist. Bring me the report and let me read the report and leave it to the person that went to school for 16 years to tell me how to read that x-ray.
I agree.
MRI is the same thing. People will bring MRIs all the time and they're like, hey, do you want to see this MRI? No. Do you have a report?
I agree, but there are some people like Stephen who just love to read x-rays. I see.
It's fun it's fun to look at them and just read them. If you don't know who the patient is, or if they didn't bring it to you and you're just reading it for fun to try to see what you can see, that's great. It is fun.
I love it when they say, I have this scan, do you want to look at that? And I look at it and it's a Titron scan. I'm like, no, put that away. I literally just say no. And they're like, oh. I'm like, yeah, I don't need that. That does not, I don't do that. That's not going to indicate anything about what we're about to do today. And they're like, oh, okay. So I can just put it away. It's like, yep, just close your phone. I don't need to see that.
I did extra papers on MRI and ultrasound outside of chiro school, just trying to get those skills. So I had some like a base level there, because it was just like extremely overwhelming whenever I would look at those images. But it takes years and just takes like time just to get good at that stuff. But there are more important things, especially if you're a clinician. I feel like there are definitely more important things that you could be focusing on. Not that imaging isn't important, but it's one of those things that chiropractors obviously do quite a bit of, right? Like the whole X-ray thing, because it's so linked to the postural line. Like there's so many chiropractic techniques out there that do draw up lines, like upper cervical and Gonstead, and so it is very linked to chiropractic. Opposed to like physical therapy. I mean, I don't know how many hours they do in their curriculum on imaging. It wouldn't be anywhere close to a chiropractor, I'd guess. I'm not sure. Do you know, Stephen?
For PT?
Yeah, you tend to know everything about these things.
No, they don't have much of any. They have like one or two classes, it seems like on average. They don't learn that stuff because for the most part, like in the US, PTs they have like a portal of entry access, but they're limited to some degree, whether it be like 3 months of care or 1 month of care, and then they have to refer back to a PCP or a GP for further diagnosis and continuation of care. So they can start treatment, but then like their big brother has to come in and say, "Oh, you're doing this the right way. No, you're not doing this the right way," even though the big brother speaks a different language than the PT. It's very weird.
That is strange. I can imagine.
Yeah, in Georgia, PTs get 8 visits or 21 days of treatment, whatever's first. And then you have to call their PCP or fax them, and you have to get assigned.
Wow.
Like, yeah, this person can see you for this. And a lot of times they don't even have to see their PCP, but if the PT's like, hey, they started seeing me because they sprained their ankle and I got to keep working on it, the PCP will just sign off on it. But at least in Georgia, I don't know about every other state, but PTs aren't allowed to order imaging in Georgia.
Wow.
At all. So like I know some of my PT friends won't even really look at it because they may have taken 1 or 2 classes in it, but they don't do it. They're not allowed to order it.
Even the doctor
reports from
is that even
because that's all it really is anymore, unless you were grandfathered in.
Because in New Zealand we don't have the doctor. It's not an option. It's a 4-year bachelor degree. And they have unlimited. They have. I don't want to say unlimited, but they have a lot of scope, just like a chiropractor. They can do a lot of stuff in New Zealand. They're definitely the main musculoskeletal career or professional that's used in New Zealand. Chiropractors are definitely the minority, and osteos would definitely be a minority as well. But believe it or not, our exercise physiologists are growing exponentially, and that's kind of taking a lot of the focus off the PTs, because like traditionally, like if you go into the history of PTs, they started out in like gymnastic type stuff. They've been moving around their scope, trying to figure out where to land, and it's even funny when PTs like get real intense about manipulation. It's hilarious. But like now that the exercise physiologists are growing so much in different parts of the world, definitely here in New Zealand, and chiros, there are a lot of, and chiros are becoming more open to other things. PTs are becoming more and more redundant. So it's kind of like, it's interesting in New Zealand at least, because it's like you can go to a exercise physiology bachelor's and be just as qualified as a physio. It's interesting how it works. I feel like we have taken you for plenty of time. We'll let you go back and be with your family. It is Sunday night for you, right, you guys? So I don't want to intrude on your Sunday night family time any more than we need to. Do we have any more questions for Dr. Eric, Luke, or Stephen? Any questions from you guys before we close?
I don't think so. It's late.
Yeah,
Past my bedtime.
Man. Your dog's waiting up for you, Stephen. Your poor dog.
He
man.
is. He's not waiting up for me.
He's not happy. Oh,
he's out.
He's gone. But yeah, thanks, guys. Appreciate your time as always, and hopefully we'll have you both back on at different times so we can continue this conversation. But have a great night, and thanks again.
Thank you.
Thanks. It was fun. Appreciate it.